During our session today, we are going to review the purpose of surveillance. We will also define the National Healthcare Safety Network, also referred to as NHSN, and the different components within NHSN and the different modules within the long-term care facility component. We will also talk about how NHSN supports long-term care facilities, how we support surveillance activities within those facilities, and then I'll briefly talk about how to get started using NHSN. First, we have a growing team on the long-term care facility side, and I have to introduce all of my wonderful team members. Namali Stone, which you just met, is our medical epidemiologist for long-term care facility and our subject matter expert. And then you have myself, and I work with the NHSN long-term care facility protocols, clinical support. You will be getting emails from me if you submit clinical-related questions. And then beside me and Namali, we have Elizabeth Mungay, and she is our analyst support, and she will actually be speaking today, shortly after me. And then we have NHSN group function support, which is pertinent to many of you out here. Our partners use group function, and that is Leah Bargan. And then we have a large user support team who will be available to answer your non-clinical related questions. And specifically, we have Teresa Marrow, who is our dedicated long-term care facility support liaison. As you can see, we have many different specialized team members, and it's nearly impossible for us to keep up with all of the independent emails that come through to us. So we do ask that all email inquiries go to the nhsn@cdc.gov box. I think many of you probably already know that, but I just want to emphasize that that is the most efficient way for you to get a response from us. Our user support will take your email and they will triage it to the correct person. If you already know who the email needs to go to, you can certainly put the name in the subject box, okay? I think we all agree that surveillance is paramount to effective infection prevention in hospitals as well as in long-term care facilities and nursing homes. Surveillance is defined as the ongoing, systematic collection, analysis, and interpretation of data. In other words, I like to describe surveillance as measuring what is going on in your population. So in the nursing homes, what is going on in that resident population in that nursing home? You can also think of it as information for action, because without correct and current data, the impact that emerging infections or emerging trends in our facilities goes unknown. We don't know. Also, our prevention programs, we may or may not accomplish the goals that we're trying to accomplish, but without surveillance, how will we know, right? And also, lastly, and I think this is really important, is our resources. How do we know where to put our resources if we don't know what the data is for our facility? So what happens is your resources get erroneously distributed, maybe to programs that don't need it as much as another program. To be most beneficial, surveillance data must be well organized. I think we all agree on that. It must also collect what's important to your resident population. I think that is critical. We don't want to collect data that's not going to be useful. I personally think that from my days being in the hospital, it's important to collect surveillance data that is targeting infections or actions that are preventable, right? Because that's the purpose. We want to prevent infection with our surveillance data. Also, it's important to disseminate that data in a timely fashion, and also to disseminate the data to the important people that need the data, right? So for your nursing homes, that may be your chief nursing officers, that may be your nursing home administrator, your patient safety officer, chief operating officer, and I'm sure there's many more that I'm not mentioning here. Now that we've talked a little bit about the value of surveillance, I want to take a minute to review the benefits of using NHSN for surveillance in our long-term care facilities. How many of you, I know that a majority of you are not dedicated to long-term care, so how many of you have used NHSN or worked with others with NHSN on the hospital side? So I'm preaching to the choir. I can sit down. Great, okay. As you know, or some of you may not know, the protocols used for reporting data into NHSN are standardized and they're validated for use across various facility types. Today, of course, we're specifically talking about the long-term care facility. The data analysis options that are available within the application will allow users to customize analysis outputs and use the data to inform internal quality improvement. So back to that surveillance that I was just talking about. Facilities can also compare infection data with other like facilities, so comparing apples to apples, oranges to oranges. NHSN data can also be used for national benchmarks, local benchmarks. You can assess your performance against nursing homes at the national level or at your local level or even against yourself. So to go along those lines, on a facility level, the NHSN data can be used to demonstrate the trends of improvement or maybe not improvement in your own infection prevention activities. Here is a schematic of all of the components available within NHSN. The patient safety, I think we all know the patient safety component. It is the most widely used component. It is tailored for use by our hospitals and other acute care facilities for infection reporting. Next, we have the healthcare personnel safety, and that is used by healthcare facilities to report healthcare staff safety events, more specifically influenza vaccination. Biovigilance is used by hospitals for reporting blood transfusion safety events. Then we've got the long-term care facility component, which is used by long-term care facilities to report infection events as well as laboratory identified events, which we're going to talk about shortly. And then last but not least, we have the dialysis component, which is used by outpatient hemodialysis clinics. So which NHSN components are available for long-term care facilities? Long-term care facilities have two components in which they can enroll and report. In the long-term care facility component, facilities are able to track resident infections as well as track staff adherence to hygiene, gown and glove use. And then you have the healthcare personnel safety component, which is also available to long-term care facilities. And within this component, facilities can track staff influenza vaccination. For today's discussion, I will be focusing on reporting out of the long-term care facility component. However, if you are interested in healthcare personnel safety component, I have the link at the bottom of my slide where you can find additional information. So let's look more specifically into this long-term care facility component. There are three modules within the component. We have the Healthcare Associated Infections module, HAI module, and currently users are able to track urinary tract infection events within this module, and that does include catheter as well as non-catheter associated UTIs. Next, you have the Laboratory Identified Event, also referred to as Lab ID event module, and within this module, you're able to identify proxy measures for multi-drug resistant organisms, or MDROs, as well as Clostridium difficile, or you may hear it as CDI. And lastly, you have the Prevention Process Measures module. And within this module, facilities are able to monitor adherence to prevention practices, and that includes your hand hygiene after contact with a resident or surfaces in immediate vicinity of that resident, and or gown and glove use in the context of transmission-based precautions. And we're going to talk about each of these in a little more detail. Certified skilled nursing facilities, your nursing homes, and your intermediate chronic care facilities for the developmentally disabled have the most options for reporting within NHSN. These facilities can use any of the three modules that I just talked about. If you are with an assisted living facility, we're not going to leave you out. You are able to use the prevention process module. So I'm going to talk a little bit about getting started in NHSN. Is there anyone in the room who does not currently have access to the NHSN application? Oh, impressive. Okay, very good. For those of you who are web streaming, this may or may not be useful to you, but I do want to go through some important steps to get you started. The first and the most important is for you to obtain support from your organization's leadership. You need that support so that you're supported throughout the reporting process within NHSM. Once you have that support, you need to identify who is going to be your NHSN facility administrator, and that is going to be the primary point of contact between your facility and NHSN. I do want to stress that the NHSN facility administrator does not have to be the nursing home's facility administrator. It's two different roles. That can be the person, but that is not a requirement, okay? A lot of times it is the infection preventionist if the nursing home has one. It could be the chief nursing officer. There's various roles, and NHSN does not assign a specific person to that role. Next, you need to make sure that you have computer and internet access. For that NHSN facility administrator and any other users who may be entering data or events within the application, because NHSN is a internet-based application. Each NHSN user must have a current email address. And if you change email addresses, there is a process that you must go through in order to change the email address within the NHSN application, as well as within the SAMS application, okay? And you could email our help desk if you ever get to that point. Very important, though, that you do that to maintain your access. And then next, the new user will need to review the enrollment training slides and the material, which are on our website, and we're going to talk about that later. And then once you've done all of that, there are some additional steps that you must take before you can get started reporting into NHSM. You must register your long-term care facility within the NHSN application, and then register yourself for Secure Access Management Services, or SAMS. You may hear it referred to as Get SAMified. And then you'll receive a nice, pretty little grid card that's going to allow you access to the application. But I think all of you in the room, most of you in the room, are already there. And then lastly, you must complete the NHSN enrollment to receive the final NHSN approval to use the application. Oh, that was a busy slide. Okay. Once you receive your SAMS access, once you've been SAMified and you have that SAMS grid card and you have NHSN approval, you are ready to log in and begin reporting. But before you can start reporting events, there are a few more things that you have to do. First, you have to set up your facility by adding the units within the facility. This is very important. We do get a fair share of questions about this. Once you gain access, you need to go in the application, and we call it map your individual units within the nursing home or the long-term care facility so that those units are set up and identified within that NHSN application. Next, if you have additional users at the facility who would like to have access to NHSN and to help you report, then you would add those additional users. And by doing that, by adding those users to the application, the application would automatically generate an email to those users with important steps of getting started to get SAMified. And then you must complete the NHSN monthly reporting plan for each month that a facility will be reporting data into the application. And then you're finally ready to report. Each month, identify and enter all of your UTI events if you're following that module, or your lab ID events if you're following that module, and or your prevention process measures. And again, this step is dependent on which modules your facility is following for that month. And then lastly, enter the applicable denominator data for each month that surveillance is performed. And I will go through these steps in a little more detail for you. Oh, one more. And resolve alerts, if applicable. And that is a data quality check that we have built into NHSN. And again, we are going to talk about those steps for those of you who are not sure. Next, I'm going to talk about some general requirements for long-term care facilities using NHSN. The current NHSN long-term care facility protocols must be followed exactly. Even if the facility disagrees with the protocols, it's important to remember that they are surveillance protocols and that in order for your facility to be able to compare your data to another facility, you must be using the same definitions. So remember, apples to apples, oranges to oranges. You also must select the Lab ID event or HAI surveillance event, and it must be performed for all locations within the facility. That's called FAC-wide in, or facility-wide inpatient, on the monthly reporting plan. So what that means is that a long-term care facility cannot choose to just do surveillance for one unit within that facility. When you're participating with NHSN surveillance, you must agree to monitor all units within that long-term care facility. And that applies to Lab ID event surveillance as well as healthcare-associated infection surveillance, which is currently urinary tract infections. Now, with that being said, and I'm going to show you in a little more detail, when you report each event, you are reporting the event for the particular unit in which that resident was residing at the time of the event. So it's a little bit different. But I'm referring to the monthly reporting plan, so your agreement. Next, facilities must indicate which modules will be followed in that monthly reporting plan, and that is for each month in which the facility will conduct surveillance. So very important. Unless your monthly reporting plan is complete, you will not be able to enter data for your long-term care facility. Very important steps, okay? So in addition to reporting the numerator, so the events, the Lab ID events or the UTI events for each location within the facility, but doing surveillance for the entire facility, the facility must, at the end of the month or soon after, report aggregate denominator data for that month, for that facility. And again, we're going to talk about that in more detail. And then each year, the long-term care facility annual facility survey must be completed within the NHSN application. If you're new and you recently enrolled in NHSN, then you completed that annual survey as part of that initial enrollment process. But just know that that same survey, maybe with minor tweaks, has to be completed each year, okay, soon after January of each year. And then for your data to be most meaningful, and what I mean by that is for you to be able to really see trends, improvements, then reporting for 6 consecutive months is really important. Okay, I've talked a lot about the monthly reporting plan, so I feel like I should tell you what that is if you don't know. So the monthly reporting plan informs CDC, NHSN, which modules a facility is agreeing to participate in a given month. Like I said, a plan must be in place before events can be entered into the application. If any of you have tried to enter events like I have, before having a plan on file, you get this nice little message that says you have no plan on file. And I even know this, and I still do it quite a bit. A facility must enter a plan for every month of the year. And within that plan, and I'm going to show you, if you're not going to monitor any events, then you simply start a plan and there's a checkbox that says, not monitoring events for the month. And check that, save it, and you're done for the month. A plan can be modified retrospectively. So let's say that you get to the end of the month and you're not following UTIs, but you notice that your facility seems to have a lot of UTIs this month. You can actually put a plan in place, go back to NHSN, do a plan for that month, and go back retrospectively and enter that data if you want to be able to monitor trends. So that's a nice feature. And then you can also enter your plans for up to 1 year in advance, which is another nice feature. So let's look at what a monthly reporting plan looks like. I don't think I have a mouse or pointer, but as you can see, there are the 3 modules we talked about are outlined here. So the HAI module, if you were going to follow UTIs, you would put a check mark in that box. And you can see the facility-wide inpatient is standard. That cannot be changed, so it's there for you. So simply just put a check in the box. The same thing for Lab ID event module, except for that module, it's always going to be facility-wide inpatient, but when you get to your specific organism type, there's a drop-down box, and you can select what organism that you want to monitor. And you would select one organism at a time, so let's say that you wanted to do C. difficile. We would select C. difficile as our specific organism, and we'd put a check mark in the Lab ID event all specimens box, and then you simply click Add Row, and that adds a second row for you, and then you could select the next organism if you wanted to monitor MRSA. And then again, Lab ID event, all specimens, put a check. And then you can add as many rows as you want for every organism that we have available in that module. And then we have the third section here is the prevention process measures module. Again, you can choose to monitor hand hygiene and or gown and glove use. Once you make your, I do want to also point out, you can see at the bottom, copy from previous month. If you, let's say that you selected 5 specific organisms that you're monitoring, it's really going to be inefficient for you every month to enter all 5 of those organisms. So you can simply start your new month, and then do you see under Lab ID event where it says copy from previous month? If you click that, it will populate everything that you were monitoring the previous month. So you don't have to re-enter that information. The same thing for prevention process measures. Don't forget to save once you complete your plan. I've done this before, and it's not funny when you do that because you have to do it all over. If you're not going to monitor a facility for a month, remember I told you to still do a monthly reporting plan because that lets us know that you didn't just forget to enter your data. It lets us know that you made a, you're telling us you're not monitoring events. So put a check mark in that box, and again, click Save. And there you have it. I do want to talk a little bit about the NHSN annual survey because it is important. Like I said, the survey must be completed at the beginning of every year. Usually mid-January is when the new survey gets populated in the NHSN application, but we'll let you know. And then I think you have until March, could be wrong, I'll have to check on that, but you have, I think, a month to get that completed within the application. The survey year represents the last full calendar year. So when you're answering these questions for 2016, you need to be thinking about what we did for 2015, okay? The variables in the annual survey are used on the patient safety, the hospital side for risk adjustment, and our plan is on the nursing home side, the long-term care facility side, to also do that when we get there, and we're excited to get there. So the annual survey is just extremely important. It allows us to analyze data based on certain risk factors that your facility may or may not have, and then compare your data with like risk factors to another nursing home with like risk factors. NHSN does have paper forms if you're still into paper. Some people are, some people aren't. You can print those forms and complete the information. We do also have line-by-line instructions for you. It's called Table of Instructions on our website, and very useful. You have to use the Table of Instructions when we're teaching this, but very detailed instructions on how to complete the form. I will say that I am not a proponent of killing trees, but this is a long survey, and there's a lot of information that you have to know. So most likely, you're going to have to print this and get the information before you start entering the data within the application, because once you get in the application and you start entering this, there's no save, I'm going to come back later button. There's save, I'm done, or you lose everything that you just did. So it's really inefficient use of your time if that happens. Okay, So let's get started. I'm going to now go through the 3 modules. I am not going to go into the step-by-step criteria for each of the modules, but what I'm going to do is take you through the what do I need to know today steps, okay? And these are based on frequent questions that I get in the NHSN box. These are based on just some common areas that we're seeing some users struggle with or have additional questions. So I thought that I would highlight those for you. And also we did have a couple of changes or a few changes for 2016. So we're going to talk about those as well. Why is UTI surveillance important? I know that I am preaching to the choir when I say this, but I'm going to say it anyway, just in case there are some of you that are new in infection prevention, which I'm sure we have those as well. UTIs are the most frequently reported infections in nursing homes. And as Namali briefly mentioned, they drive antibiotic use and misuse among our residents, right? I think we all know this. So if we can get a handle on what UTIs we have in our facility, then maybe we can branch out and also look at how are we treating these infections? How are we treating these non-infections? Next, focus monitoring of symptomatic UTIs, both catheter and non-catheter associated, helps to identify trends in those infections. And again, provide data to improve antibiotic use in long-term care facilities. So going back to that surveillance slide that we talked about. And then lastly, tracking these infections will also inform infection prevention and control staff of the impact of targeted prevention efforts that you have in your facilities, which is really important. The UTI protocol was adapted from the revised McGeer criteria, the 2012. So if you're interested in any of the rationale for some of the protocols, especially the UTI, I would say review this or read this article. It has got great information. I've been doing long-term care with Namali for a year now, and I read this article like once a week just to refresh my memory of why we do what we do. It's a great article. Actually, Namali was an author on this article, but I do encourage you. It has great rationale, and not just the NHSN criteria, but other criteria as well that you may be interested in. I do have some UTI protocol updates for 2016. Hopefully you're happy with these. Presence of a fever, even if due to another cause, should be counted as part of meeting the UTI definition. We're making this change, or we made this change to remove the subjectivity in the UTI protocols. We were getting a lot of questions about, well, the resident has a medication that could cause a fever or may not, or the resident has a decubitus ulcer that may or may not. So just to maintain objectivity across all of our facilities using it, we made this change in the definition. This is different from the McGeer criteria, I will say. The next change that we made, and this is has been made across NHSN modules, starting with the patient safety component, is yeast and other microorganisms, which are not bacteria, will no longer be accepted as UTI pathogens. So what do these changes mean for long-term care facilities reporting into NHSN for 2016? So fever can be used to meet SUDI criteria even if the resident has another possible source for that infection, or that fever, pneumonia as an example. Only urine cultures meeting the colony count requirement for at least one bacteria will be used to meet the NHSN criteria. So you can no longer meet the UTI criteria with yeast alone, okay? Coming to this, did everyone, when you came in today, that has a resource manual, for those of you web streaming, this is not pertinent necessarily to you because you don't have a resource manual, but for all of you who came in, did you pick up one of each? Very important, we had a mistake in our algorithm here, and it has been corrected, but it was corrected after the resource manual went to the printer, unfortunately. So please tear out the incorrect ones. Just take them all the way out, because I would hate for you to take those manuals back to the long-term care facility IPs and them accidentally use what's in here. So take them out completely, replace them with these. The protocol on the website does have the corrections as well. So if you printed the long-term care facility UTI protocol prior to February the 7th, you're going to want to trash that copy and reprint it, please. I'm hearing ripping. I love it. I've got to give you guys just a minute to do that. So I also, on this slide and the next couple slides, I just try to highlight within this figure what the changes evolved around, so that you would know. So here you can see the note: yeast and other microorganisms are not acceptable UTI pathogens. Same scenario here for your figure 1 ABUTI criteria. Toss it out and replace it. And then it does not impact the SUDI criteria, so keep this one in the manual. I know I've already talked about the monthly reporting plan, but I want to talk about it again. I just want to show you an example of what it would look like if your facility was following the UTI protocol, just so that you have this visual in your head. So again, we've already talked about it must be completed in the application. And this is just a visual of if you're going to report a UTI, or if you're going to monitor urinary tract infections for the month, you would go to the left-hand navigation bar under reporting plans. You would click add, and then when you get to this page, you're going to see your facility ID, which will be pre-populated for you. You're going to select the month that you're going to be reporting UTI events and the year, and then go to the HAI module and put a check mark in the UTI box and then save. So this plan is what a facility would see if you're only reporting UTIs for the facility. Just a reminder, there are 2 specific types of UTI for long-term care facility reporting. That is the symptomatic UTI, or SUDI, and then the asymptomatic bacteremic UTI, or ABUTI. For both types of surveillance, they apply to both catheter-associated as well as non-catheter-associated UTI events. Moving right along to some other key points to remember when reporting UTI events. UTIs can occur in residents with or without an indwelling catheter. The symptomatic UTI protocol criteria combine both sign and symptoms as well as laboratory and culture data. The asymptomatic bacteremic UTI is for residents who have no signs or symptoms that are localizing to that urinary tract, but they do have positive urine culture and blood cultures that match for the same bacteria. We get some questions about mixed flora. Mixed flora is not considered an organism and cannot be reported within the NHSN application. There is no organism type for mixed flora. So if you have a UTI and mixed flora happens to be one of the findings, you would not report the mixed flora, okay? Again, we talked about this. Yeast cannot be reported as an organism for a UTI. This means urine cultures with yeast can only be included if there is at least one qualifying bacterium. And in that case, when you enter that event, you would not enter the yeast into the NHSN application. In fact, it won't even be an option for you. You would just enter the bacteria. To be considered as catheter associated, the catheter must be in place for a minimum of 2 calendar dates, where the day of insertion equals day 1, And it must be in place at the time of the event or removed within the 2 calendar days prior to the event onset, with that day of removal equaling day 1. Just a few more key points. And this is a variance from the hospital UTI protocol, if you don't already know that, and that's why I want to just make sure everybody understands the date of event for UTIs in the long-term care facility module is the date when the first clinical evidence, which be your signs or symptoms, of the UTI appeared, or the date the specimen used to make that diagnosis was collected, whichever comes first. Infection should be attributed as an HAI for that long-term care facility if there was no evidence of incubating infection at the time of admission to the facility. And again, you will base this on what's in the chart, so the clinical documentations of appropriate or applicable signs and symptoms, and it's not based solely on microbiology data. And the onset of clinical manifestation occurs greater than 2 calendar days after admission. So what you're really looking for, if you have, is a change in baseline for that resident. Something new is going on with the resident. And I hear some facilities say, well, the residents had a UTI all month. No, probably not, but they may have positive urine cultures all month. So you need to look beyond the urine cultures and really take a deep dive into the clinical picture of what's going on with that resident. Has there been a change from the normal for that resident? Has there been a change if it's a new resident? Is there a change from what we saw or what was documented upon admission? And that's really what you're looking for. I do want to point out that at the present time, the long-term care facility protocol does not have a set time period during which only one UTI may be reported for the same resident. Following a UTI, in order to determine if a second UTI should be reported for that same resident, and again, I'm referring to either present on admission or healthcare-associated infection, you're going to want to look at that clinical information and use that information, what's documented in the chart, to determine if that original infection had resolved before reporting in the UTI. So this kind of goes back to the old days for the hospital side, right? This was what patient safety the hospital started with. And so that's what you're going to do. Information that may be useful may include new onset of signs and symptoms, as well as the resident already completed antimicrobial therapy and appear to be getting better, and then all of a sudden the fever starts back, the dysuria or other symptoms come back to maybe point you in the direction of a new UTI or a new UTI event. Just want to review what we consider at NHSN the definition of an indwelling catheter, and that is a drainage tube that is inserted into the urinary bladder, and this does include neobladder if you have residents with such. Inserted through the urethra, it is left in place and is connected to a collection system. This collection system may be a collection system which is taken apart and used for irrigation. Those are still counted, okay? Or intermittent indwelling catheters. I think you may see quite a bit of that, but those are still included. So even if that sterile seal is broken, you must still count that resident for indwelling catheter days, as well as if a UTI develops. What does not qualify as an indwelling urethral catheter, straight catheters do not qualify. Same thing, in and out catheterization, condom catheters or Texas catheters for your male patients. Suprapubic catheters do not qualify. Nephrostomy tubes, urostomy tubes, and ileal conduits do not qualify. So I think that's where maybe you're trying to wean a resident from the catheter, or for some reason they're having a procedure where you need to close the catheter off so that urine can build up in the bladder, perhaps. Does anybody else have, and we can talk about that in questions, talk a little bit more, because there may be some other folks in here that have a better definition for you. Okay, let's talk about the numerator form. Event forms are available on the NHSN website. One form should be used for each event type. So this event that we're looking at is the urinary tract infection form for long-term care facilities. These forms are for a convenience, or they're for a convenience for our users, but also know that the forms are designed so that you, the user, is collecting important information that is required to meet that definition that you're trying to meet. And it's information that you will be required to enter into the NHSN application when you're ready to enter the event. You may print these forms if you'd like and use them, give them to your staff. The forms do come in PDF and Word version, and I think this is great because if you print or if you open up the Word version and save it to your desktop, you can customize that form so that it meets the needs of your facility. And I think that's great because each of us may do a little bit different surveillance practices. But keep in mind, even if the form is customized, the NHSN protocols must still be followed, okay? Exactly, when entering that data into the NHSN application. So I guess what I'm trying to say is you can put whatever you want on this form, but what you enter into the application must match the protocol and the definition. And I have the link here for you to access the form. Oh, there's also a table of instructions for this form. So every form that we have the table of instructions. And those are step-by-step details of how to complete the form. They're really great if you haven't used them in the past. Highly recommend the table of instructions. Okay, I think you guys are going to love LabID after all of that, right? Going to move into laboratory identified event reporting, or LabID event. So I want to talk about first, why is it important to monitor C. difficile infections in our facility or multi-drug resistant organisms in our facility? We know that residents and long-term care facilities are at high risk of either being carriers or acquiring C. difficile and multi-drug resistant organisms, such as your MRSA, VRE. Infections from multi-drug resistant organisms, as well as C. difficile, can be more severe, harder to treat, and are associated with increased risk of hospitalization, debility, and death, especially in our older adults, older than 65 years of age. We also know that focused monitoring on multi-drug resistant organisms and C. difficile helps to evaluate the trends and changes that are occurring in these pathogens within our facility. And then tracking these events will also inform our infection prevention staff of the impact of targeted prevention efforts that we may have in our facilities, or maybe prevention efforts that we need to start within our facility. Just to give you an introduction into LabID event, or laboratory identified event, NHSN defines a LabID event as a proxy measure for multi-drug resistant organisms and C. difficile. So it allows limited resident admission and transfer data, as well as laboratory testing data, to be used without clinical evaluation of that resident. And what that means for you all is that it's much less labor intensive, a much less labor intensive way to collect the data that you need to enter for that resident. There are many advantages to LabID event surveillance. This type of surveillance enables users to easily apply objective surveillance definitions to estimate healthcare acquisition, infection, and exposure burden within our facilities. Participating in LabID event reporting also guides the implementation of interventions, as I just discussed. And it allows your facilities to easily monitor those interventions. Are they working? Are they not working? Where do we need to make adjustments? Do we need to make adjustments facility-wide, or do we need to make adjustments on a particular unit within that long-term care facility? And since We use standardized case definitions for lab ID event reporting. Facilities are able to compare rates and trends across clinical settings as well as across months or years for their own facility. The metrics that are used in the Lab ID event module were adopted from recommendations from published literature from the Society of Healthcare Epidemiology of America, as well as the Infectious Disease Society of America. And these are great reads if you have some spare time, because I know you all do, right? Just to make your eyes cross, I put this slide on here. Here are the reporting options available in the Lab ID event module. So C. difficile, or CDI, which is near and dear to my heart. And then you also have multi-drug resistant organisms. Facility can choose to monitor one or more of these organisms. So you have your Staphylococcus aureus that's methicillin resistant, so your MRSA. Facility can also monitor Staphylococcus aureus methicillin susceptible, MSSA, in conjunction with monitoring MRSA, if you want to look at maybe the trends with the susceptibility patterns of your Staph aureus. You can also choose to monitor vancomycin-resistant enterococcus species, or VRE. Then we have cephalosporin-resistant Klebsiella species, carbapenem-resistant Enterobacteriaceae, or CRE, and with that is a package deal. If you choose to monitor CRE, then you're monitoring your Klebsiella species, your E. coli, and your Enterobacter CREs in your facility. And then we also have the multi-drug resistant Acinetobacter species. So all of these options are available to you. You can choose one or more to monitor for your facility. And each month, if you wanted to add new ones on, when you get really good at Lab ID event surveillance, go for it. Because Lab ID event is so much, because it is streamlined surveillance, I think it's easier to monitor these other organisms. We do have some protocol updates for the Lab ID event for 2016. You may have noticed that the question, has the resident been discharged from an acute care facility in the previous 3 months, has been changed. It is now 4 weeks. And we did that because we had this data, and it's great data, but we realized we really weren't using anything beyond 4 weeks for when we're doing analysis. And so now we've changed it to 4 weeks, and that hopefully is going to reduce your surveillance burden, and it's going to better align with the ACT-LO categorization, or the acute care transfer long-term care facility onset, which we're going to talk about. That's a tongue twister. And then we've just made some clarifications based on feedback from you all in regards to specimens collected from outside facilities. So for Lab ID event reporting, it is important that you're only reporting based on specimens collected within your facility. So if the resident is transferred to your facility from a hospital and they collected specimens, that's in the hospital, that specimen is not applicable for Lab ID event reporting for your facility. In a perfect world, that would be great if all of the electronic systems talked and we had that great data, but we're just not there yet. So we just made clarifications throughout the modules just so that it's clear that specimens collected while the resident is receiving care outside of the facility should not be included in Lab ID event reporting for that facility. So those are pretty easy changes. Again, this is what your monthly reporting plan will look like if you're just following the Lab ID event module. So within here, you can see that I've chosen to follow MRSA and C. difficile. And if I wanted to add CRE on there, I would just simply click Add Row and add in the CRE. And then don't forget to click Save when you're ready. To give you a definition of a C. difficile Lab ID event, it is a C. difficile positive laboratory assay tested on a liquid stool specimen and collected while a resident is receiving care in that long-term care facility. And the resident has no prior C. difficile positive laboratory assay collected in the previous 14 days while receiving care in that facility. You may also see this in the protocol or hear this referred to as non-duplicate Lab ID event, CDI Lab ID event. Just want to clarify what I mean by positive laboratory assay. A positive laboratory test result for C. difficile toxin A and or B, and this does include your molecular assays or PCR testing, or it can also include a toxin-producing C. difficile organism detected by culture or other laboratory means performed on a loose stool sample. Just as a reminder that the stool must conform to the shape of the container in order to be considered a qualifying specimen. So we say it must be liquid/loose and conform to that container, okay? The easiest method would be to have policy in place in your laboratory so that specimens that do not meet that do not conform to the shape of the container are rejected. And that way you know that you're only reporting CDI lab ID events on qualifying specimens. Definition of your multi-drug resistant organism or MDRO lab ID event. Now this is a little bit different. MDRO positive laboratory test tested on any laboratory specimen source, so you're looking at all specimens when you're following the MDRO module, and it's collected while the resident is receiving care in that long-term care facility, and the resident has no prior positive for that same organism from any specimen source collected in the same calendar month. Okay, really important. So this is a little different. So this is in the calendar month and it's any specimen source. Okay, the exception here is when you have a unique blood source. Okay, and I'm going to talk about that on the next slide, but I do want to point out that MDRO lab ID event does exclude tests related to active surveillance. So your nasal cultures, your rectal cultures for screening are not applicable to this and should not be reported as a lab ID event. Unique blood source. This is a multi-drug resistant isolate identified in a blood culture from a resident with no prior isolation of that same organism in the blood, collected in the blood in the past 2 weeks or 14 days. Okay, again, it's while receiving care in that long-term care facility, and this crosses calendar months. Okay, so probably have to read this a few times. This is another one of those definitions that I'm constantly reminding myself that they are a little bit different. Just a note here, a unique blood source isolate must be reported even if the resident had the same MDRO previously isolated in a non-blood specimen earlier in the same calendar month. So the blood trumps that non-blood, okay? And I think I have some examples coming up. Oh, here we go. We're going to test you. So we're going to assume that Mr. Smith is our resident. And do you guys have the answers? Oh, okay. Well, I guess you're going to get them all right, but I want to go through and talk about the logic. Okay. Assume that this is our line list for Mr. Smith, and these are the only specimens that we have for him. So he was admitted, our current admission date for Mr. Smith is 2/1/16 for all of these. So the specimen collected on 2/2 is a urine specimen with MRSA. Should we report this as a lab ID event? Yes. And the reason is this is his first MRSA from any specimen source for this calendar month. Next, on 2/17, we have a wound, which is MRSA positive. Do we report this as a lab ID event? No. And the reason is this is not a blood source, and he does have a prior MRSA isolated in the month already, so we don't report it. Then on 2/21, he has a blood that's positive for MRSA. Do we report this? Yes. And the reason is this is a unique blood source, and he does not have a prior MRSA positive in the blood in the previous 14 days. So then on 2/26, he does have another positive MRSA blood. Do we report this? No, because it's been less than 14 days since his previous positive MRSA blood. 2/28, he has a nasal screen with MRSA. Do we report this? No, because screening tests are excluded. 3/1, he has a blood that's MRSA. Do we report this? Ooh. So that's kind of tricky. So no, we don't report this because even though it's a new calendar month, he did have a previous MRSA blood within 14 days. So what about the urine that's collected on 3/11 for MRSA? Do we report this? So we do not. And the reason is because he did have a MRSA positive specimen in this calendar month. Remember, so for non-bloods, it can be collected from any specimen source. So he already has one collected. So if you look at this, really, we've only reported in 2 months. We reported 2 lab ID events in February and none, or none in March. And you will not report one in March, but unless it's a blood that occurs after 14 days from 3/1, so 3/15 on, okay? Just a reminder, duplicate lab isolates are based on the most recent lab test for the resident and not the most recent lab ID event. Okay, so when you're looking at the 14-day rule, you're basing it on the most recent lab test, not the most recent lab ID event that you've entered. So it's really important to keep a line list of your specimens so that you're not entering duplicate lab ID events. Just some key points. Lab ID event date is the specimen collection date. Very easy. Only non-duplicate specimens should be entered into NHSN as a lab ID event. And then we've already talked about this a million times, but lab results available from other healthcare facilities before the resident was admitted to the long-term care facility should not be reported as a lab ID event. Okay, lab ID event reporting is only for collecting and tracking isolates from positive cultures that are taken for clinical purposes, so diagnoses and treatment. So that means those active surveillance culture testing, nasal swabs, or perirectal swabs are excluded. So I want to talk a little bit about how NHSN categorizes lab ID events. So the NHSN application categorizes these events for you. So it takes the guessing or the research out for you because you enter the events and the application does all of that guesswork for you. So the lab ID events are categorized based on the current admission into that long-term care facility and the date of specimen collection, or your event date. So you have community onset lab ID events, and those are when you enter a lab ID event for a resident, and the specimen collection date / lab ID event date is collected 3 days or less after admission to the facility. So specimens collected on day 1, 2, or 3 are all considered community onset. Then you have your long-term care facility onset lab ID event, and that's when the specimen was collected more than 3 days after admission to the facility, so on or after day 4. For your long-term care facility onsets, those also have another sub-categorization. So just for long-term care facility onsets, the application further classifies those as acute care transfer long-term care facility, or ACT-LO. And what that is it's a long-term care facility onset lab ID event with a date specimen collected in less than 4 weeks following the date of the last transfer from an acute care facility. And what I mean by acute care facility is a hospital, a long-term acute care hospital, or acute inpatient rehabilitation facility. Just to give you a little schematic of what you're looking at. So you can see here March 1st, 2nd, and 3rd are all considered community onset if that's the if our admission date is March 1, and then the March 4th and 5th are long-term care facility onset. Now, for C. difficile lab ID events only, this only applies to C. difficile lab ID events, they are further categorized based on the current specimen collection date and prior specimen collection date of a previous CDI lab ID event entered into NHSN. So you have an incident CDI lab ID event, and that's any CDI lab ID event from a specimen collected more than 8 weeks after the most recent CDI lab ID event entered into the application. Okay, so more than 8 weeks since that last lab ID event was entered into the NHSN application. Or if it's the first CDI lab ID event for that resident. That would be your incident case, okay? A recurrent CDI lab ID event is any lab ID event entered greater than 2 weeks. Okay, so anything under 2 weeks would be a duplicate, right? So greater than 2 weeks and less than or equal to 8 weeks after the most recent lab ID event reported for that individual resident. I know that this is a lot to take in, and we're going to continuously give you help on this because the categorizations can be overwhelming. But again, the good news is that the NHSN application does it for you, okay? Want to do a knowledge check, and we're going to go pretty fast through this because I'm running close to time. So again, we're going to assume all of these C. difficile test results for a resident, one resident in a long-term care facility. So 1-3, the resident has a positive C. difficile. Is this a duplicate? No. So this is the first specimen for that resident, so it is considered a CDI lab ID event and should be entered into the application. And then a 1-9, is this a duplicate? Yes, this is a duplicate because the resident had a previous positive C. difficile specimen 6 days ago. So the specimen should not be entered into the NHSN application. Okay. Oh, I didn't give you the answer. 120, what's the answer? Okay, so I want to explain this one a little bit. So 120, it is considered a duplicate. So remember, it's considered a duplicate because it's based on the most recent positive CDI lab ID test. It's not based on the most recent lab ID event. So the 120 is a duplicate because the resident had a positive C. diff on 1-9, right? And then what about 129? This is a duplicate, and so we do not enter it because it's within 2 weeks of the most recent positive test. And then what about 223? This is not a duplicate. It is a new lab ID event because the resident has not had a CDI in the last 14 days. Now, I want to bring something up to you just to make you aware. So going back to the 120, it's really important to keep a log of your positive specimens because the application has a business rule built into it that will not allow a user to enter a duplicate lab ID event. However, that duplicate lab ID event, the application doesn't know about all of the positive specimens that the resident had, right? It only knows about the positive specimens that have been entered as a lab ID event. So if we were to enter, so the application would not let us enter 1-9 because that's clearly a duplicate from that first lab ID event. But on 120, it is a duplicate, but the application will let you enter it because the application only knows about the 1-3 specimen, okay? So when you're working in nursing homes, or many of you are working with nursing homes, it's important that our nursing home users understand that so that they're not overcalling C. difficile in their facilities. Okay. Again, here's the numerator form. I've already talked about this for UTI, but we have the same form. We have table of instructions on how to complete the form. You can put this form on your desktop and customize, but just remember that you still must follow the lab ID event definition as written in the protocol. Talk a little bit about denominator forms. Similar to the numerator forms, we have these denominator collection forms available on our website as well as the table of instructions. You will use one form for the entire month, okay? Again, the form is designed to collect the data that's required to be entered into the application. We have this available in Word and PDF, so you can customize if you wanted to. I'm going to move on to prevention process measures. I'm going to speed up a little bit, and I apologize, but let's talk a little bit about why it's important to monitor adherence to prevention process measures in long-term care facilities. We know that the hands of our healthcare personnel are easily contaminated during caregiving or simply from contact with surfaces that are in close proximity to a resident, or maybe in the nurses' station when other nurses haven't washed their hands. And these organisms that are picked up on the hands can easily be transmitted to our residents and cause a healthcare-associated infection from within the facility. Hand hygiene is one of the most effective ways to prevent transmission of healthcare-associated infections. I know we'll all agree to that. Gown and glove use by healthcare personnel when residents are placed in transmission-based contact precautions have been shown to reduce rates of healthcare-associated infection transmission. And then it also this protocol also reinforces and supports the CDC and HCPAC approved guidelines for the prevention of healthcare-associated infections, and informs your infection prevention and control staff of the impact of performance improvement efforts. Have a link to the CDC HCPAC guidelines if you're interested. It's on the slide. Okay. To calculate, so the purpose of this module is to calculate rates of adherence to hand hygiene or gown and glove use, as well, and to use those opportunities to improve practices in your facility. It's also good to provide feedback to your healthcare personnel on adherence to hand hygiene and gown and glove use. It's interesting when people don't know you're looking, what happens in your facility. And then also to assess the impact of efforts that you may have in place to improve hand hygiene and gown and glove use in your facility. There are no protocol changes within this module, happy to say, for 2016. Here's your monthly reporting plan. If you can see here in this reporting plan, I decided I wanted to follow everything. So I'm looking at our UTIs in our facility, I'm looking at C. difficile and MRSA in the facility, as well as I am monitoring adherence to hand hygiene and gown and glove use here. Some key points I want to bring up. To participate in the module, a facility can choose to perform monitoring of hand hygiene or gown and glove use, or both, okay? What that means is they can do hand hygiene alone, but if they choose gown, they must also use gloves. So it's gown and glove, they're combined. It's a package deal. Or they can monitor all three. To get the most out of the data, a minimum of 6 months should be reported during a calendar year. A minimum of 30 unannounced observations should occur per month for each event, and that is what we recommend to be most effective, to get the most effective data. Monitoring must be performed facility-wide and include all types of healthcare personnel. So don't just target your nurses or your doctors. Look at all of the healthcare personnel that are coming in, your physical therapists, your OT, anyone who may be providing some sort of care to that resident. And then also long-term care facility staff, other than the infection preventionists, can be trained to perform the observations and collect the required data elements. So go out there and get your cheerleaders and have them doing these secret observations for you. I mean, my experience is that they love it. It gives them a sense of purpose. Okay, where am I? Okay. Here is the monthly form for prevention process measures, and you can see for hand hygiene, numerator is going to be the number of hand hygiene opportunities performed, and your denominator is going to be the observations that were indicated. So when were they actually performed? When it was required. The numerator for gown and glove use is the number of contacts which gown and gloves were correctly used, and the denominator is going to be the total number of contacts for which gown and gloves were indicated. We have data collection forms available to you. I do have some time to go through the denominator. If a facility does choose to submit data to NHSM, you must also submit denominator data soon after the end of the previous month. You can use our forms if you want, or if you have another method of collecting your denominator data, that works too. So you can see here the first column represents the number of residents. So for each day of the month, if you use this form, you would put the number of residents in the facility. So date 1, how many residents are in your facility? Okay. Do not include residents for whom you are holding a bed, but they haven't actually been admitted. Only include the residents that are actually in the facility. The next column, number of residents with a urinary catheter. You're going to complete this only if your facility is performing UTI surveillance for the month. Otherwise, you can skip that one. The next column, number of antibiotic starts for UTI indication. Again, only complete this column if you're following UTI for the month. The next column, number of admissions. You're going to record the number of residents admitted to a facility, and you want to include both new admissions as well as readmissions. And then in the last column, the number of admissions on C. difficile treatment. If a facility is performing lab ID for C. difficile, you would complete this last column. Otherwise, you could skip that column. Okay, at the end of each month, you would aggregate all the data in the form if you use that form, and you would only enter the totals in the NHSN application. So to do that, you would go, log in, go to your navigation bar on the left-hand side, and click Add, and then the facility ID will populate. You're going to select your month and your year. And then once you do that, this page, or you'll scroll down to this page, and everything with a red asterisk is required for you to enter data for your facility for this month. I do just want to point out that the new antibiotic starts for UTI indication. I want to talk about this a little bit because we do get some questions. So for this box, you will enter the monthly sum of all new prescriptions of antibiotics that were given to a resident either suspected or diagnosed with having a UTI, and this includes catheter or non-catheter associated. So this does not mean that the resident has to meet the NHSN criteria, UTI criteria, okay? Okay, so you're going to count it even if the resident did not meet UTI criteria. And also just point out that there are no minimum number of doses or days that the resident has to be on that antibiotic, okay? And then also just want to provide you with some clarification around the number of admissions on C. difficile treatment. That's the monthly total of admitted residents who were receiving antibiotic therapy for C. difficile infection at the time of admission. Again, it includes new admissions and readmissions. And you want to count the number of residents on C. difficile treatment even if that resident does not meet the NHSN criteria for a lab ID event. On the summary data form, it's going to look like this within the application. You will notice under each organism there are red asterisks, and those are the report no events, and this is really important. When you get to this form, if there's a red asterisk, that means you need to put a checkbox in that box, or check in that box, because that means that you are monitoring. So let's look at MRSA. We're monitoring MRSA because there's a check mark that says that we are. So that means that in our monthly reporting plan, we say we're monitoring MRSA. But there were no events entered into the NHSN application. So that box is available, and you just simply put a check mark in that box. And what that's saying is, yes, I monitored MRSA all month, but we did not have any MRSA events. And that's just a quality check so that we know that you realized you were monitoring MRSA and you just did not have any. And you would do that for each of the organisms that appear on here. And if it's not applicable to you, the box will be disabled, okay? And if you check this box, and let's say you're doing retrospective data collection and you realize, oh, I did have a MRSA, but I checked the box already, it's okay. Once you enter the MRSA into the application, the box will automatically uncheck for you. You don't have to do anything, okay, but enter that event. 3 minutes to go. I think I can do it. So last but not least, you need to resolve your alerts. And this is important. It's an embedded data quality check within our application. When you log in, if you see these pesky, we've heard them called pesky, action items, that means you need to do something. And because they're not going to go away until you have action. So what you would do is you would click on each hyperlink, and it's going to open the list of alerts that are applicable to that. So let's look here. Let's go back. Let's say that I clicked on that 3 incomplete events, okay? Once I click that, this is what comes up on my page. It shows me that I have 3 residents that I, for some reason, did not complete entering the event data, but I saved them anyways. So I did not put specifics on the slides, but what you would do is you would click on that event number, and it takes you to their event page. And most likely what it is that you left out an element of the UTI protocol, okay? So keep that in the back of your head that if it's a UTI event, you probably did not fully enter all of the criteria that's required to enter, okay? Incomplete summaries, this is really important. This is your denominator data. So if you were to click that button, it's going to take you to the summary. And 9 times out of 10, the error in your summary data is that check no events box, okay? And then, so for that one, that's exactly what it was. So you see the box for Klebsiella, those are disabled. And because they're disabled because I'm not monitoring that for the month. But you see the one for C. difficile, there's a check box, but I just need to check that there were no events. And just if you do not check that box, or if you leave these alerts unresolved, then your data will not be included in any aggregate data analysis, okay? So if you're participating in a collaborative and you have events that are unresolved or alerts that are unresolved, the data that you entered will not be included because it's not considered as complete. Okay, we made it with 2 minutes to spare. If you have questions, come to the mic. We will be available, throughout the day to answer questions if you don't want to go to the mic. So it's up to you. So we have our brave soul.
What output and analysis is already available for long-term care?
Oh, that is an excellent question. And guess what? That session is coming up. You have pretty much everything except for the SIRs that's available on the hospital side. You're going to also see, I don't see everything, but a lot of stuff you're going to see the same type of output options available on the long-term care facility side. And Elizabeth is going to show you today some screenshots and some different options available. Are you a Quinn QIO? And so one thing that So yeah, Elizabeth's going to talk about it, and I'll talk to you on the side too. I have some ideas for you. Okay. Any other questions? Well, thank you guys.
One more.
Question.
And it may follow along, but the definition of a UTI that the RN attests to on the MDS seems to be a little different than the definition that we're given here.
Yes.
And I mean, it's an uncomfortable position when someone is attesting with their license and sending it to CMS. And then, so I'm wondering if we'll get guidance on helping us reconcile those two different things.
Yes, we will. Let's talk offline about that because, yes, I hear exactly what you're saying and can see the concern there. I just don't have an answer for you right now.
That's okay.
Namali has an answer, though.
Okay.
So we have like 30 seconds.
Just so people can hear me. So this is a very important issue, and I know that it does cause confusion for nursing homes when they are looking at the MDS. For those of you who are not familiar with nursing homes, the MDS, or minimum data set, reflects sort of the assessment inventory that's done when new nursing home residents enter a building, and then it's done on regular intervals to track progress in their health status and functional status and so on, and it's used as a billing tool. The criteria for defining a urinary tract infection by MDS really maps to the original McGeer surveillance definitions from 1991. And when the revision to the definitions occurred in 2012, MDS 3.0 had just come out, right? So it come out in 2010, I believe. So it was just an unfortunate series that all of that work CMS had done to create and update the MDS 3.0 happened before the published new criteria for surveillance occurred. They are aware of that and have actually reached to us to talk about ways to reconcile that difference. I cannot provide a timeline for that, but it's not gone unnoticed, and we don't want providers to be in a situation where they feel like there's a surveillance definition here and it doesn't match to their MDS reporting over there. So thank you for that question.